Well, welcome everyone to our Lunch and Learn today at the National Scoliosis Center. I have the pleasure and opportunity to introduce Dr. Laurel Blakemore. She's going to be speaking to us about vertebral body tethering today, which we're very excited to learn more about. We get lots of questions about it. We deal mainly on the bracing side, but there's lots of interest. It's really great to understand all the options for our patients for treatment of spinal deformities. You know when you have a full-page bio and it only scratches the surface that we're in for a treat. Dr. Laurel Blakemore is recognized internationally as a leader in the care of spinal deformities in children. Her clinical practice is based here in Northern Virginia at Pediatric Specialists of Virginia, in addition to Washington, D.C. at Children's National. And we have the pleasure of working closely with her, being here at PSV and near her, which has been great. In addition to her clinical work, she stays very busy serving as the Chief Executive Officer for Pediatric Specialists of Virginia. In addition to that, she also participates in international study groups focusing on pediatric spinal deformity and continues to contribute to other areas of research to improve the orthopedic care of children. She's published multiple peer-reviewed manuscripts and book chapters, is an associate editor for Spine Deformity and reviewer for other peer-reviewed journals, and has served as a visiting professional nationally and internationally. She served on the board of directors for the Pediatric Orthopedic Society of North America and the Scoliosis Research Society, or SRS. So for SRS, she served as the Secretary and Governance Council Chair, the first female elected officer for that society. So please join me in welcoming her as she speaks about vertebral body tethering.
Thank you for that lovely introduction. I'm really glad to be here to talk to you guys, my downstairs neighbors. I know we said patients back and forth on us, so I'm pleased to be here. And I'm going to talk about tethering, which I have been doing. I'm not the sort of first line of surgeons, which I'm sure you know some of the names. Really, the people that I look to and work with on tethering have been, Peter Newton in California was one of the first people that learned it. I actually had Stefan Perron come down from Montreal and do my first case with me in 2014. There's been more and more people really interested in this area, and as you know from talking to your patients, there's lots of patients interested in it. But I'll kind of tell you what we do and don't know, and I'll give you a warning that there's probably a little more that we don't know still that we do, especially compared to kind of our gold standard in terms of treatment, surgical treatment. So these are my disclosures. I do have IP in this area, and I'm currently serving on the Pediatric Spine Foundation board. So there's three ways to try to use. We've been using growth in pediatric orthopedics for a long time to try to make things straighter. We use it in leg bones like genivarum and Blount's disease, problems like that. And we've been using it in spine some really for the last 30 or 40 years. But vertebral body tethering is kind of the newest and most promising iteration of that. So there's vertebral stapling, which was one of the earlier techniques, then vertebral body tethering, and that sort of phased out stapling because the results weren't quite as promising. There are newer ways to look at posterior growth modulation, but those are all still really in the experimental stage as well. So we're really going to talk about anterior vertebral body tethering. This is kind of what the procedure looks like, so if you don't get into the operating room. You basically do it in the chest thoracoscopically or in the lumbar spine through a mini open approach. And you put in screws and then tie those screws together with a rope and put pressure on the spine on one side, on a growing spine. I'm among the people that are strong believers that this isn't really a technology that's applicable, at least not in its present state, to any spine that doesn't have a fair amount of growth remaining. Because the tethers fail, as we'll talk about in a little bit. And even if they didn't, you really need to get growth modulation to achieve lasting correction. In the old days, people tried single rod fixation, and as you know, there was anterior spine fusions that initially were done and had a fairly high failure rate. So if a solid rod can't hold it, it's really been challenging to build a tether that can hold it, or a rope, basically a flexible rope. So this is kind of how they can look. This is a 2-year outcome on a child that I did, one of my earlier kids, and it can really be, it's like gambling. It can be fabulously rewarding because the kids look great, they're straight, their correction is wonderful, and they have motion, and we think that's important. But what we really understand about that motion is a little bit limited, and I'll talk about that later. So the appeals of growth modulation as opposed to fusion, which I would say is our kind of current gold standard for surgical treatment, is that it uses spinal growth to get permanent correction. So in theory, if the tether failed or broke, the permanent correction would be held. It causes less muscle scarring and blood loss, for sure. You're not ripping the spine, the muscles off the back of the spine and putting in big rods, which is really appealing. And it seems like in 2022 we have a better way by now of fixing scoliosis, but really we don't. We're still stripping all the muscle off and fusing. It's motion sparing. We'll talk about the data on that. And I'll show you that it's a little less predictable right now with increased complication rates. There is potential for pulmonary impact anytime, especially going into the chest, and particularly with revisions where there's a fairly high percentage of mini open and open procedures. And we don't really yet understand what motion sparing means to the patients. So even though the patients are very enthusiastic about the idea, and there's a lot of information that makes patients feel like fusion is going to be really terrible for their motion, I'll show you what we do and don't know, and it's not as different as you think from spinal fusion. So this is a patient, just by example of how these can look. This is a 7-year-old girl that I treated for idiopathic early onset scoliosis. She was braced. It wasn't one of your braces. She progressed, but it was a good brace. I mean, she wore it well, but she continued to progress. And at this stage was Sanders 2 with a curve in the 50s that was flexible. So we felt that she was a good candidate. I would say now that we know that maybe even a Sanders 3 might even be a better candidate, but at the time, so this was about 4 or 5 years ago when she got her tether. This is how she looked preoperatively. She really did have a lot of rotation for not that big a curve. And I'll show you how much that did or didn't correct. So I don't know where I have pre-op actually. There we go. So we did performed a tethering procedure. The curve was really a little bit close to 50 degrees when we did it. We got good correction on the table, which is one of the things we now understand is important. They have to get them down less than 30 degrees. And then at 4 weeks post-op, they usually rebound a little bit, which is what we expect. And over time, this child really did growth modulate. She really did improve from her first standing erect x-rays. And this is how she looked at a year. Still a fair amount of rotation, but a little trunk shift. And then we continue to follow her. And if you see what happens there at the bottom, you see how she's starting to overcorrect a little bit? This is not an uncommon problem with tethering, especially at the distal end. We've learned a little bit how to address that. But she got a little bit more waistline asymmetry than she had, and at 2.5 years, that was how she looked, but she was really slowing down her growth at that point. It was post-menarchal. How this kid's going to look in 5 years or 10 years, that's a really good question. So far, she's quite pleased with it. Her left shoulder got pushed up a little bit, but she's really happy with her clinical result. So this is an example of, for sure, there's proof of concept that it works. So let's talk about what we do know so far. The first couple of papers that came out, the first one, as you know, was out of Children's Shriners Hospital, Philadelphia, Dr. Semdani, who's a fabulous surgeon and does a lot of work. I think some of the patients from this area still get referred to him. And he had good results. Sort of proof of concept, he could get overcorrection. So some of these kids really do correct so far that they get a curve the other direction, and that has to be addressed. He did really young children, Risser 0 to 2. We weren't really Sanders staging yet at that point. So Risser, as you know, is a little less precise. You can argue how precise the Sanders score is. It seems better for us. It's certainly another piece of information. So we've kind of gotten away from using the Risser score, but you'll see the early studies in tethering use the Risser score. And then there were a couple more papers that showed no major surgical complications. They had some fairly big series. It seemed safe. It seemed like they could get good correction, but again, saw some kids really add on or overcorrect when they were tethered young. Then Dr. Newton, who was, again, one of the early adopters, showed us a really worrisome study. First he presented it at SRS, and then he published it. And in that study, there was really high incidence of tether failure with our current implants. Almost half of the people demonstrated evidence of the tether failing. Now, the failures didn't always need to have surgery, but 50% required at least another tether revision to replace a broken tether or cut a tether that was overcorrecting, or ended up failing and having a spinal fusion either recommended or performed. So when they published this, which was a couple of years after, again, half with a broken tether, 9 out of 23 patients, I believe, that had a fusion either performed or recommended. That worried everybody. So everyone was like, wait. That's not as good as we would expect. That's not as good as we would even have with posterior fusion. So we're rethinking. So the most recent data suggests a couple things. One is there definitely is a higher risk of complications. sorry, let me get ahead of this. This was the White Cloud Award that Dr. Newton and I got to participate in that showed a big group of patients matched to posterior fusion patients. So again, we're kind of comparing to our gold standard. And the complication rate was clearly higher. 16% had revisions versus 2% of the posterior fusions. 10 of the tethers had loose or had to remove the tether, 4 had their tether replaced. So absolutely there's a higher revision rate, and patients need to understand that when we consent them for a tether, we explain that although it's FDA approved, it's experimental. There's clearly a higher revision rate compared to our current gold standard posterior spine fusion, and that's one of the things they should expect. So is it really a better option? And I'll show you a couple papers just kind of comparing, again, posterior fusion to tethering. This is one that was presented at IMAS. It was a multi-center first matched comparison of vertebral body tethering to posterior fusion. And this was in lumbar tethers, and this is where I think really the best results, or the most important results for tethering may occur. In the thoracic curve, we'll talk about that a little bit. So in lumbar tethers, we compared posterior fusion and Linking 5 curves in terms of the outcomes. It was a comparison analysis. So I think it's important, again, when you're looking at a new technology, you have to look at the tools you have and say, are we doing better or not? And if not, we need to think hard about making sure patients understand that when they're consented. The LIVs were a little different in these two groups. So we had basically a slight difference in the LIVs with some more of the posterior fusion patients tethered to L4. So you can argue that the curves were maybe a little bit different. But in terms of the surgical outcomes, the SRS outcomes were comparable. There was no statistically significant difference overall in the SRS outcomes. Maybe a little difference with pre-op, post-op self-image. When you compare the vertebral body tether group to the fusion group, maybe a little difference again, but nothing reached statistical significance. And the complications were different and higher in the tether group. So there were a few complications in the posterior spinal fusion group. But some of the tethers had to be converted, some of them had to be reoperated on for overcorrection, some of them had to be reoperated on because the tether failed and they had to put it back in. So the revision rate was 26% versus 13%, which sounds high for posterior fusion too, but in a lumbar group you might expect a little higher revision rate than in the thoracic group. So equivalent curve correction, which was good, but a higher revision rate. So who should we be putting this in with, given just that information alone? Like, how can we make sure kids look more like this and less like that? And this is another child that did that. I would have thought we would have argued that these were comparable curves to that other child that I showed you that did great, but she fell off. She basically added on and fell off to the right and ended up with a posterior spine fusion. So everybody who's been doing tethering for more than a couple of years has had some kids that have ended up with posterior spine fusions. So one thing we've learned is that's a sweet spot of the combination of the right size curve and the right amount of growth is pretty narrow. This paper showed that there was a progressive correction in the Sanders 2 and 3 patients, meaning they looked better at 2-year follow-up than at their first upgrade. Their curve continued to improve. But once they get to SMS4, that's not so much happening. And SMS4 is pretty early in their growth, just after peak height velocity, right? But if you tethered anybody Sanders 2 or smaller, they had a really high rate of overcorrection. So it's that leaves you with Sanders 3 and 4 as sort of your indication. And so it's got to be the right size curve. If you tether a child who's maybe a Sanders 2 coming 3, arguably, you could do a little bigger curve, a 60-degree curve maybe. If you tether a Sanders 4, it better not be a 60-degree curve because you're not going to have as much opportunity for growth modulation. That means it's a pretty narrow window. And again, the revision rate is 6.5% required reoperation, either for a broken tether or for overcorrection. So it can modulate growth, but it doesn't always. So even in the kids that we think are perfect candidates, that are Sanders 3 and 4, we don't always see actual modulation, actual improvement from the first direct films. And there's a lot more data just even in the last year that's starting to come out on this. There is correction in some kids, but predicting which kids that's going to happen in has been challenging. This study that Hirschmeyer did in 2020 showed that in COBs that were in COBs that concluded with less than 30 degrees, they They were longer tethers and a little more mature, which was kind of strange. He did Sanders 5. But they still had a pretty high broken tether rate, 21% revision rate. So again, we're sort of batting about a 20 to 25% revision rate in all these studies. Of the half that were considered really successful, there were a few still with bigger curves, and again, 2 out of 4 had to 14 had posterior spine fusions. I think what's really important, and I mentioned that we probably don't know as much as we don't know more than we do know, are these things. And one is, what's the effect on motion? And I'll talk a little bit about the couple studies we have comparing the effect of motion to posterior spinal fusion. Effect on pulmonary function, nobody's really studied yet. And I'll show you at least what we know about anterior open procedures. And the long-term outcomes is what nobody can know yet because we don't have long-term really yet. The longest studies are 8 years. So, number one, is it motion sparing? The answer is, short answer is probably. Let's talk a little bit, I think to understand motion sparing in tethering, you have to understand what the current sort of state of the art is in terms of motion in fusions. So how bad is the motion in posterior spinal fusion, number one, and then how much can we improve it with a tether, and then the big money question is how much does that matter to the patient long term. So the motion in posterior spinal fusions. Posterior spinal fusion patients, clearly the lower you go on their back, and you'll hear us tell patients this, and that's why it's a bummer to have a lumbar curve and not less so a thoracic curve in my opinion, is because the lower you have to go, the worse their motion is, clearly. Below about L2 is when you really start to see a difference, and as you go L2, L3, L4, their motion declines. Michelle Marks did this study looking at motion. This is quoted a lot. In fact, we use this, I'll show you, we use this technique in a study that Feroz Morangi did that I'll show you on motion below a tether. When they looked at motion in lumbar fusions, what they really looked at in this study that's I say off-quoted, is motion below the fusion itself. And what they saw was the motion distal to the segment was really not very different at 10-year follow-up, but there was a subset that had long fusions that showed basically increased motion in these segments. So paradoxically, you might say, or it makes sense, if that segment is stiff, the motion below the fusion became hypermobile, so to speak. And the theory is that that is what makes those discs wear out over time. So if you're fused to L3, and that's happening at 3 active levels, then maybe you'll be okay for a while. And it looks like people who fuse to L3 really do pretty well in intermediate and long term. L4, not so much, because there's even more stress, and predictably, you'd say even more motion at L4 and S1, and then L5, if you're fused to L5, all that motion is hinging through one disc. So, and again, this was a study looking at posterior spinal fusions assessed with a measuring tape. And they didn't see a huge difference in patients fused to thoracic thoracolumbar spine. I'm sorry, and this is in patients at 10 years post-op, so pretty long follow-up. But they did see some reduction in lateral motion. So this is a different way to look at it. Rather than looking at radiographic motion, which is a little bit hard to get through an IRB, and understandably so, it's more radiation for the kids. This is looking at clinical motion, which, I don't know what you guys think. I think it's probably hard to measure accurately clinical motion with measuring tape, but we don't have anything great yet unless you're going to do a gait lab. And we'll talk about what my experience with the gait lab. This was an older study looking at patients that had a fusion versus brace versus control, all with scoliosis. The muscle and endurance and motion were lower for the fusion patients and for the brace patients. Better motion and muscle endurance were correlated with better function. Pain was the same in all the groups, which was interesting. And this is common sense, I think. What level they stopped at in the lumbar spine affected lumbar mobility, so the ability to touch their toes, and they measured this clinically. And then this is again an older study looking at sort of their function that showed that fusion patients were performing as well for age and sex matched patients in terms of trunk strength as patients that hadn't been fused. So even though there's a difference in motion, functionally these studies suggest that maybe it doesn't matter in ways that we've been able to understand to the patient, at least at intermediate term follow-up. We do see more anterior
adjacent disc disease after fusions, and again, the lower you go, the more adjacent disc disease you see. So incidence overall is about 9%, but the longer the fusion and the lower the fusion, the more adjacent disc disease you will be able to demonstrate. So again, this is using that sort of other motion look. This is the effective time and fusion length. And this is the same group that looked at that hypermobility below the fusions. They showed that in a 10-year follow-up period, fusing longer resulted in this greater summed motion below the fusion than in those patients who had like a selective thoracic fusion. So you see this sort of hypermobility, and again, we speculate that that hypermobility is part of what causes this adjacent segment disease. Okay, so that's fusion patients. Well, what about motion preservation? How different is that in terms of the motion? So we don't have very much data, is the truth, but we have a couple studies. This is a study that was published this year looking, and again, which I think is really the best methodology to use. They matched tether patients to patients fused posteriorly and had 3-year follow-up, which is pretty good follow-up. They did a clinical range of motion evaluation, so basically having patients bend forward and measuring their clinical motion. And they showed a difference in the motion. Let me see if I have that. So, oops, sorry. So they showed that the patients that were fused had improved mobility overall in terms of their range of motion, but it was not very significant. They also had better muscle endurance and flexion extension. Well, that makes perfect sense to me, right? If you don't rip all the muscles off the back of the spine, they're going to have better muscle endurance flexibility. So that's good. That's something that we can actually identify that might be important to patients long term, but we don't know yet. We just know that they demonstrated this improved muscle endurance with repeated exercise. The other thing that they showed that was interesting was that their SRS scores were better in the tether patients, and that's not something that's been uniformly the case. But at least in this study, they showed better SRS-22 outcome scores. And you can argue whether the SRS-22 scores are the best. People are more and more turning to a different outcome score called PROMIS, or another kind of outcome score that can be applied that we think might be more able to capture real patient functional outcomes. But for the moment, SRS-22 is kind of the standard for spine deformity patient studies, and this showed a difference. We did a study in Florida where we used a gait lab, so we really wanted to try to do a little deeper dive into the motion. And we compared tether patients to fusion patients. We had pretty small groups, and we used the patient as their own control. So we did gait lab motion analysis with all the mirrors and cameras, looked at their motion pre-op and post-op, and used themselves as their own control. What we saw was a little bit of difference. So we saw better, and this was all thoracic tethers. Nobody fused or tethered below L1. We didn't have large enough numbers to match those two, but we were at least able to sort of use basically selective thoracic fusions versus tethers. In those groups, we saw a difference in the motion in the sense of trunk extension and rotation, but it was pretty small. There was a couple other interesting findings, like dynamic trunk to pelvis rotation during walking was different in the fusion patients than in tethers. None of this has really been demonstrated in terms of what it means long-term to patients. So we can say they are a little different. We can say we don't exactly know what that's going to mean for the patient long-term. And then this study, which these are slides from Feroz Mayanji, and this was a study that they showed, which again was a really good methodology to compare post-op motion between fusion patients and tethering patients. They did a similar technique to what Michelle Marks and that group did, and they tried to compare the motion in two groups that were matched for length of fusion and a 2-year follow-up. And again, they looked for this sort of hypermobility below the fused segments. They also tried to look for motion in the tethered segments. And this is and they had to do it radiographically. So this is something that's a little challenging to get through an IRB, but they were able to do this. So these are the two groups in this study that were matched. They were comparable, other than the fact that the spine fusion group was a little bit older, which makes sense because you're trying to hit that sweet spot in terms of their skeletal age. So they were doing a little bit younger group for the tethers than for the fusions. Otherwise, the groups were comparable. The tether group actually had, interestingly, a little bit bigger major cod, but the number of instrumented levels were the same. the percent curve correction was the same, and the LIVs were matched. So the total motion that they saw in forward bend was not significantly different between the two groups. I would have guessed it would be, but it wasn't. The total motion in the unfused groups, though, was different. The unfused groups acted more like a native, an unoperated on spine, I should say. The fused groups did what had already been proven in in the previous study. They had hypermobility below the fusion. So although they didn't necessarily see a functional difference in terms of how far they could bend forward, they saw a difference in where they bent forward. So they bend forward, if they're fused, they achieve the same motion by hypermobilizing their unfused distal segments. I think that's probably important. I think that this study is sort of the first indication we have that this is really going to be possibly more important in the lumbar spine than in the thoracic spine. Again, this just shows the motion in the unfused, uninstrumented segments wasn't that different, but the summed motion below the fusion or tether was different. And this is just another study showing that the more distal the LIV, the bigger the difference was. And so this is the solid line is the posterior fusion group, and the other line is the tethers. And the tethers basically are acting like a control, like a patient that did not receive surgery, and the fusion group is developing that hypermobility as you go distally. So that's kind of all we can say. And no, we can say that they maintain motion, but more importantly, they didn't change the distal segment motion as much. And I think that's probably where the difference may show up in terms of how patients do with a motion-sparing technique like tethering versus a fusion technique in the lumbar spine. And I think that's why it's going to be different than the thoracic spine. So let's say they do get extra motion. We think they do. Is it worth it? We haven't been able to prove that very much in terms of outcomes. And again, you can argue that our tools aren't the best tools yet, SRS-22, but they haven't been super different. There was a study that showed that the two groups weren't very different at baseline. And then a couple only other studies that we really have good SRS-22 data on show, interestingly, the tether groups were maybe a little more unhappy with their curves before surgery. But the follow-up median scores were basically similar, other than a little bit of difference in self-image. So there's been questions as to whether tether patients are sort of self-selecting for tethers because of some pre-op factors that we're not really understanding yet in terms of mental health and self-image. But I would just say that I think the conclusion is there's conflicting information about that, and we haven't really seen a big difference in terms of patient-reported outcomes. So motion may be different. We don't know what that means. We can't document any patient-reported outcome difference that seemed to be significant. What about pulmonary function? Does pulmonary function change at all if you go into the chest? And again, this applies for thoracic tethers. We know it can if you go anteriorly open. So there have been a fair few studies that showed a small but real decrease in pulmonary function if you went anteriorly compared to open surgery or with open surgery compared to posterior fusion surgery. Barry Launer did a study that showed this little sort of small deficit in thoracoscopics versus open, which had a real deficit. So I would argue that any patient that's going to get a open or a mini open procedure following their thoracoscopic surgery, meaning for a revision, is at risk for some effect on their pulmonary function. Whether these small effects, 5–10%, at 2 years are really going to turn out to be meaningful to patients long term in terms of their pulmonary function, it's hard to say. Everybody's pulmonary function declines with age. So the theory is that if you have a significant deficit at this stage, it may turn out to be something more important to patients long term. So there's concern about repeated thoracoscopic procedures. I think the bottom line with thoracoscopic tethering is it seems to be okay to go into the chest once. We're worried about going into the chest multiple times, and I think we should be. Any technology that we have really needs to be improved to the point where the likelihood of that tether failing and having to be reoperated on is negated. To tell a patient that it's okay, your tether is going to fail, and we're going to go back in a couple of years and put it back in, and then we're going to go back in a couple of years and put it back in. I promise you, there's a higher rate of mini open and open procedures with those revisions. And if that's the case, nobody's really looked at the pulmonary consequences of that, but they need to. We need to. This is just one sort of scary study that looked at anterior procedures. It was done about 10 years ago out of St. Louis. And what they saw was a real but negligible change in the posterior fusion patients. And again, that's been controversial. There have been some studies that show posterior spinal fusion patients get better pulmonary function. But the anterior group had a significant decrease in the percent predicted pulmonary function in FEV1. So unlike the posterior group, when they compared any kind of anterior procedure, thoracoscopic open, anything, they saw a real small but real statistically significant decrease. Nobody's really been able to make anything out of this or know what this is going to mean for patients long term. But I would just caution you that, and I think that all of us that are studying, so we just had the meeting of the posterior spine study group, and pediatric spine study group, and everybody in that group has agreed that pulmonary function testing is important as we look at our results with tethering. This is just one last study that showed with a mini open approach, and this is the only study I could find like this, pulmonary functions actually rebounded at baseline to 2-year follow-up. But that's the only one, and that's with a single procedure, not with revision procedures. So I think the verdict is we think there's going to be some effect on pulmonary function if you violate the chest wall, but it's probably negligible with a thoracoscopic procedure. It's much more worrisome that there could be an effect with repeat or open procedures, and we as those that take care of pediatric spine patients need to be aware of this, I think, and understand how pulmonary function is going to be affected by thoracoscopic procedures, especially repeat thoracoscopic procedures. So what I make out of all this is I think the best candidates are in that very narrow sweet spot, 40 to 60 degrees. That whether they're still good for it at 60 degrees depends a little bit on their Sanders stage. So maybe a 60 degree with a smaller Sanders stage. As you get up into a bigger Sanders stage, closer to 40 degrees. They should be people that have either come in and are not a candidate for bracing or have failed bracing. So pretty much everybody thinks that if you see a 40-degree curve, you should at least either have documented progression or have tried a brace and failed before you would consider a tether procedure, because that's really below the indications for fusion. They shouldn't have too much of that rotational rib deformity like that first girl I showed you, because that is not expected to correct very, very reliably or very predictably. They should have just that amount of growth left right now. That seems to be Sanders 3 is the perfect one. 2 to 4 is the range. Some people will push that up to 5. If you're tethering patients that are Sanders 6, 7, 8, it's really at this stage with what we know unclear that that's an appropriate use of this growth modulation technology. And I personally think it's probably going to be the most beneficial for a kid like that who has a double major curve, and we really are going to fight to preserve the motion in the lumbar spine. I will tell you sort of anecdotally that among that group that was there last week, people are really reporting that some of the centers that have done the most thoracic tethers are moving to fusions for the thoracic curve, or basically a hybrid technique where they're fusing the thoracic curve, because the cost relative to a tether seems to be, I mean, the tether doesn't seem to be worth the squeeze, so to speak. The juice isn't worth the squeeze, but still considering tethering the lumbar spine where that motion is going to be so much more important. So that's the kind of correction that we can get. So what questions can I answer now that I've given you a bunch of questions that we don't have answers to?
Just along those same lines, so you would go in and do a spine fusion. This is just based on this lesion. A spine fusion on the thoracic, but on the lumbar, you would do a tether, all in the same patient.
Yes.
Oh, okay.
So yes, so there are patients getting double tethers at centers that you can do, and the options would be to tether both curves the same day. Some surgeons stage it, so that's 2 anesthetics for that child, or you can say it's, you can argue whether you should do 2 shorter anesthetics or 1 longer, but I would say the majority of surgeons who are doing double tethers, which is not very many, are doing it in the same day. But you have to reposition them. You would go to one side, then you flip them. You can do the top couple thoracoscopically, and then make a little opening in the diaphragm. Go down and to do a mini open and connect the tether, because you can see that one goes above and below the tether, above and below the diaphragm, and then you repair the diaphragm. There have been a couple reports of diaphragmatic hernia from getting that access. So it's not benign, but again, for this kid with this 58-degree curve, if this works, I think it's a win, especially if that correction holds it 10 years and 15 years. For the child with the thoracic, if she had a 58-degree thoracic curve, it's hard to argue with. I'm not saying that posterior spinal fusion is the end result, is our best that we can ever do, but it's hard to argue with the clinical results and outcomes of a selective thoracic fusion. It's a T12 or L1 in terms of function and complications. And if you're comparing it to a technique that yes, it's less invasive and muscle sparing, but has a higher complication rate. Yeah, I think we're really careful to consent patients so they understand that. And personally, I feel like my thinking has evolved to at this point, I would encourage people really to think about it with a lumbar curve, if they're in the right age group and they have the right amount of growth left and right size curve. And I'm counseling more and more patients to consider a selective thoracic fusion if they come in for a tether, but they really have a main thoracic curve only. It's a work in progress for sure.
Thank you.
Would the upper anterior fusion and the tether, would they be done in the same procedure?
Upper anterior?
What, didn't you say there were some that were upper anterior, there upper fusion?
I didn't show that. There's a couple, just a couple that I know of that I don't know that anyone's doing that a lot. So like for a Lenke 2, you mean? Like a big stiff upper thoracic curve?
Right.
You certainly could consider that because you can't tether up that high.
Right.
You can't really tether reliably above T4, and T4 is not that much fun to get to thoracoscopically. There's like a vein the size of my thumb. But so T5 is fairly reliably easy to get to. T4 is challenging. To get to T3 up on the other side, you can't. That's very hard. So right now, most surgeons won't tether a child who's already has a Lenke 2 and already has left shoulder elevation. Whether or not you could do a little fusion there, like a little T2 to T5 fusion and then a tether.
But that would be two separate procedures, right?
That'd be two separate procedures, right? A posterior fusion of the left upper thoracic and a tether of the main thoracic. That's certainly something you could consider, but it's not.
Okay.
It's not something that anybody's really reported on yet or anything like that. I've seen like a couple of cases like that. But again, selective thoracic fusion, even if you had to go to T2, the results are pretty reliable. So unless, it may be a game changer when the tethers become more predictable in terms of not failing. Right now it's fairly predictable that they're going to fail in a large percentage of the patients. If that changed and they didn't fail, then maybe a different question, but we're not there yet.
Okay.
And people, and what you really want is one that you could program. You want to be able to put the tether in and then say tension it a little more because you're not getting enough correction, and then say stop tensioning or back off on the correction because it's overcorrecting, but there's nothing like that. Yeah.
Okay.
Have you seen a difference in the recovery time and return to sport with fusion versus tether?
Anecdotally, yes, we are looking at that right now in the posterior spine study group. Anecdotally, I would say that they come in pretty bouncy at 4 weeks and look pretty good, and the tethers sometimes do too, and sometimes take a little longer. If that were the only difference, it probably wouldn't be worth it. But I'd say that they do bounce back pretty quick. There haven't been, as I say, it's been pretty safe. There've been a few patients that have to have a chest tube reinserted. And if you look at the studies and the complications, but really the surgical complications aren't very high. They predictably do pretty well in the post-op period, and they're kind of ready to go. People haven't been as strict about restricting them either. They used to, with fusions, people used to say, well, you can never go back to sports. Then it was a year, and then it was 6. Now it's kind of 6 months for collision sports and 3 months for non-collision sports. And
That's pretty good.
the tether's really kind of more like whenever you feel like it. Nobody really can think of a good reason you shouldn't let a tethered kid go back to playing sports once they feel up to it, because you're not waiting for the bone to fuse. And we don't think it's going to make the tether fail faster, and there's been very few reports of the screws pulling out or breaking. I did have one broken distal screw, but I think I've got one of the few, and that was at a year and a half post-op.
That's pretty good.
Yeah, so surgically it's pretty reliable and it's pretty well tolerated.
Is the source of the tether fail the material or the growth, or
something else?
It fails. So you anchor it down to the screw with a little locking screw. With this iteration, so that there are other companies going as fast as they can to produce sort of comparable devices that maybe will address that. But with the device we have, you lock it in place. So everybody thought, well, it must break right there where the set screw hits it, like that cuts the fibers.
Yeah.
But when people have gone back in and looked, it isn't always like right there. Sometimes it's right in the mid substance. Sometimes it fails at multiple levels. Sometimes it only fails at one level. But yeah, and you can the way you measure that, and we've kind of gotten better at understanding that it's failing and measuring it. So you just measure like the angulation, and you'll see one that all of a sudden it'll be 5 degrees more angulated, and then maybe you'll lose correction. If they're still growing, you might lose correction. If they're totally grown, you may not see any big change, and that's why we may be underreporting it, because there may not be a big change in the angulation if the kid's totally kind of got what they got, and then the tether's not really holding any correction anymore, and it has failed, and it may be hard to diagnose. And people have talked about putting a metal marker in it, but then there's a worry that metal breaks, it can cut the thread, it'll make it more likely to fail. So it's been hard to figure out how to really assess it. Do we do MRI? I mean, how can we see if it's broken or not, other than whether the screw angles change, whether the screws start to splay apart more.
Where do you see this going the next 5 years in terms of things that need to improve to make it more successful, or is it in the hardware? Is it the techniques? Or do you think it's going to be limited?
I think we would prefer one that doesn't break when we don't want it to. I think, but like I said, it'd be great if you have one that you could program it to break when you get the kids straight, so they don't overcorrect. We don't have that. But you'd want one that does what you tell it. So if you put it in and you don't want it to break yet, it'd be nice if it didn't. So the tether itself should be different. The technique, as I say, the technique is pretty good. I mean, it's a pretty limited, even for lumbars, it's a pretty limited approach compared to like an open lumbar. And they tolerate it well. But the predictability, I think, is up to us to understand, to really study it. I mean, I don't think anybody should be doing this who's not studying. I don't think it should be available to anybody who's not studying it. And so that we can understand, like, some of the things we've learned so far, like, not such a good idea on a standard 65-degree curve. That we only find that out because we're honest about reporting our results, and we collect our data. If you're not collecting and submitting data, I kind of have a problem with it, because it is experimental, and I'm not saying we shouldn't be using it. We should be consenting patients appropriately and giving them the option and telling them the pros and cons of trying this versus not. And when I can send somebody for a thoracic tether, at this point, I tell them, well, it's motion sparing, but we still don't really have a great understanding of what it means to be motion sparing in the thoracic spine. We think it's more important as you go distal. And that could change. Like in 10 years, somebody might be able to demonstrate that motion is better. But I don't think so. If you look at selective thoracic fusions, their results, long-term, their functional results, in terms of being able to do things, sports and bend and move, are very good. So it's got to beat that in ways that are important. You can say that sparing the muscle is important. So if tethers were just as reliable as a thoracic fusion, and it held up perfectly, and you didn't have to revise them any more often, and you could do it minimally invasive, that might be a good reason to do it in and of itself, to do a thoracic tether. Just to say that it's less of an operation, less muscle destroying than a posterior spinal fusion. But as long as it's higher revision rate and higher complication rate long term, which is where it currently stands for thoracic fusion, it's a harder sell, I think.
So what happens if a tethering fails on a patient that's completely grown? Then what?
So some of those patients don't, at least if you look at the study, basically the longest outcomes are like 5 years. Don't necessarily have to get revised because they're holding that correction.
Okay.
So that tells you that they growth modulated, and that's another next step, is to really do a better job understanding how does the shape of the vertebral bodies change. It's hard to study in a 2D X-ray because some of it's rotational, but But if you can study that in 3D and show, okay, this wedged apical vertebrae, those 3 wedged apical vertebrae got to be rectangular again, and they're going to maintain that correction, then that'd be great. So then you could say, oh, I don't care if the tether fails at 5 years if all my kids got to 10 degrees or less and they're sort of below some minimum threshold where they're going to stay put.
Okay.
Then I think it would be a win.
But what if you don't get correction and
Then they'll progress.
And-
If you're only corrected, so if you're relying on this tether basically to
Yeah.
apply mechanical correction to a curve, kind of like an internal brace, well, what happens when you take the brace off a 50-degree curve? It falls back up. So pretty predictably some of them fail.
Okay.
And I think, again, that depends how much growth modulation they got before it happened. But in a perfect world, we wouldn't have to worry about it happening at all.
Right.
Until we want it to. Until we hit the button and say, break tether.
Do you think you could go less aggressive with the tether and then night brace in combination?
I don't know the answer to that. I do have one child who had a double major curve that the lumbar curve was smaller. I think you guys are bracing it. That has a tether and a brace for a nighttime brace for a lumbar curve. That's more fine tuning than we've been able to do so far. I like to say, well, maybe we're getting too much correct. Probably we're not. I mean, the ones I can tell you that the data suggests that the highest rate of success is in flexible curves. So they have to be bend down to 30 degrees or less on benders, and they have to get down to less than 30 degrees on the table. And if you get them down to less than 30 degrees on the table, and they're Sanders 3 or 4, they have a likelihood of achieving good correction.
Okay.
But that's a pretty small group of patients. Which is why, I mean, most of us, even places like Shriners in Philadelphia, Dr. Samdani says he turns away way more patients than he actually offers tethering to, because they're either too old or curve too big, or. And they are doing more there. They are doing more thoracic fusions for those kids now than they were 3 years ago, and then lumbar tethering, is my understanding.
About how many are being done on a monthly or quarterly basis in the region?
That's a good. Well, in the region, not that many. Probably, I know Children's probably does 1 or 2 a month. I've done a couple since I've been up here. Philadelphia does, I'm sure, 3 or 4 a week, because they have a national referral base, and they have a couple surgeons, Dr. Cahill, Dr. Sandani. There's one other one I can't remember. So there's a couple surgeons that are tethering at one center.
But here locally, it's probably still a half dozen a month. at the
Yeah,
most.
I would say. Yeah, I mean, it's not, like I said, it's a fairly narrow window if you keep your indications as tight as the data would suggest currently. I mean, I really want to tell you, I think it's going to be the right answer for lumbar curves. I hope it is, if you can catch them when they still have enough growth remaining, because those lumbar curves are pretty flexible, but lumbar curves can overcorrect like a son of a gun with a tether, because they are pretty flexible, and there is, I mean, the reasons that sometimes when you tether a thoracic curve, just like thinking about this one, like these levels are the ones that will tend to overcorrect, and then they start to get this funny sort of thoracolumbar curve the other direction, and you have to go in and release it. A little bit like my first girl that I showed you.
That's where you'd like the button to break it.
That's where you'd like to say, to break at those 2 levels, but not at the rest. Yeah. And we put slack in. When we put a thoracic tether in, like down to T12 or L1, we like push a centimeter of slack in. It's totally, we're just trying to, because we've seen over the past 5 years that those levels overcorrect, is where that overcorrection can happen. So most surgeons you turn the screw about a half, there's different ways to do it, but you basically don't tension that bottom level, and then the tension in theory builds up. There's also some interesting new data about stress relaxation. Like people have been trying to measure how much tension we put on, because now it's just totally eyeballing it. And it looks like you can Pat Cahill in Philadelphia is doing that. You can tension it, and then that tension relaxes a little bit, like pretty quick. So it's we still don't understand how it works.
Are you locking at each spot, or just the full
Yeah.
length of the tether?
Yeah, I mean, I don't think there'd be any point in putting it in without locking it and just letting the tether free slide. You might as well just not do that level then. And you might argue, well, why do you do the bottom level even with a little bit of slack? It's because if you don't, then sometimes they break off the other way, and like that right thoracic curve will go that way because they'll get developed adding on right at the junction. So it seems like you want to have it there. It seems like you don't want to tension it very much or not at all. it's been very hard to be scientific about how much tether tension to apply is the right answer. I'm sure it varies by the size of the kid and how stiff the curve is and how, all those things. So we don't have, it's not like, you're supposed to put 5 newtons worth of pressure on this one and 2 on that one. We kind of go like a little, a lot, none. That's basically as scientific as we've gotten so far. There are places measuring it, but it's not universally measurable.
So each segment is individually tensioned as you're going down?
Yeah, and most of the time we tend not to tension the top very much.
Okay.
Tension pretty aggressively in the middle because you're trying to get that apex down there towards corrected, and you push the kids up on their side, so you push down on the spine and really try to get a lot of correction and level the disc spaces at the apex.
Okay.
And then back down at the bottom, you put a little slack in the tether at the end, because that's the level that we know can be a problem.
Yeah.
But the apical levels you really want to get, in a perfect world, you get them on the table, you get them looking kind of parallel.
Okay. So that's what you'll try to do your best to align it then, get an ideal picture, tighten there, and base the tension off of feel and kind of experience.
Yeah, and then if you don't think you have 30 degrees, about 30 degrees or less of correction on the table, then you probably need more correction. If the curve was flexible enough pre-op, you should be able to get that.
Okay.
I did take care of one child who was done somewhere else and all I had was the surgeon's intraop fluoro shot, and he got her quite straight on the table. And I know that because when she came back to me, not very long after, maybe 16 months after he operated on her, she had a 40-degree curve the other direction.
Wow.
So it's a proof of concept. It absolutely growth modulates in some kids. We have to identify exactly which kids are going to growth modulate and try to get a better estimate of how much they're going to growth modulate. But it absolutely can overcorrect. And this one wasn't his fault. She was lost to follow-up. Yeah. But when I look back at the correction he got on the table, it was like a lot. I mean, it was pretty close to straight on the table. And then she grew a lot.
Yeah.
And then I had to go in and release her tether for the curve the other direction.
For post-op, any contraindications both for the fusion as well as the tethering in terms of movements you want to avoid or postures you want to assume?
We don't really know if they need much in the way of restrictions for tethering. I mean, I've gotten pretty laissez-faire about letting them go back to activity when they're ready after a tether. Okay. For fusions, we are sort of trying to study that. Because there's 2 different things. There's what you tell the patient to do, and that's totally based on I've always done it that way right now. And then there's what the patient actually does, which is probably somewhat different. So we're actually getting a survey organized to sort of ask the patients, really, when did you get back to activity? And really, how long did that take, and what did you do, and what did your surgeon tell you? Because I have plenty of kids that for sure go back before I tell them. Yeah. Right now, most surgeons, or just in polling surgeons, most surgeons are letting kids go back to non-contact sports at 3 months and collision sports at 6 months. But some are doing any sport at 3 months, like football, whatever.
Sorry. The hypermobility you're talking about with the spinal fusion, from the patient's standpoint, would that feel sought after the surgery? Would developing that kind of hypermobility, give you more movement?
It does. I mean, it probably is why they didn't see a big difference in movement between the fusion patients and the tether patients in the one study, but they achieved that clinical motion by achieving hypermobility in the lower segments, which is probably detrimental in the long term. Okay. But that's why they didn't see a big clinical difference, is that there was more motion in those patients that were fused longer. So in other words, the tether patients had sort of more uniform, normal motion that achieved whatever, touching their toes. The fusion patients could, when they could touch their toes, did it by hypermobility through L4 to S1.
Right, okay.
So that's probably not good, because that's probably what helps wear out those discs.
Just to be mindful of time, because I know it's after 1 o'clock. Want to take one more question?
Sure.
Okay.
If there is one.
I have one just regarding pain afterwards and how when they experience it. Typically, I know for just general surgeries that we typically see, sometimes pain could be there for years. There's so many different factors that feed into it. So what has your experience been with tetherings and fusions in terms of the kids and their kind of expectations for both the kids and the parents regarding pain?
I think mostly for fusion patients at the 4-week follow-up, the majority are pretty comfortable. But there are, of course, exceptions that continue to have pain, like maybe between their shoulder blades is sort of a typical one for years, and that may be from stripping all the muscle off the spine and the parascapular muscles.
Okay.
But that's a little hard to predict. Although when I look at my SRS 22 before and afters, most of my patients who've had a lot of pain after had a lot of pain before.
Okay.
But that's anecdotal. I mean, there's better studies. In terms of tethering, I really haven't had much in the way of reported or, like in my experience, long-term pain. There's been 1 or 2 patients that all complain of numbness from the port.
Okay.
And there's like sort of dysesthesias around their chest wall from probably pressure on the nerves from the port, because it's a big 15 millimeter port. It's like a garden hose through the ribs. And the chest tube stays in for a couple days, but we're getting kind of the smaller chest tubes. So they do have some pain sometimes from that, but like internal spine pain, not so much, because you don't really have to strip anything. You just kind of, poke holes about this big between the ribs to get the ports in, and once those heal, they're generally quite comfortable in my experience.
Okay.
So I'd say they get better a little quicker.
Okay.
But at 1 year follow-up, I don't know that I would say there's a difference that I know of. It's a little bit like plating a clavicle fracture. I mean, if you plate a clavicle fracture, they feel better quicker, but at 1 year follow-up, the results are basically the same. So, except that the people with the clavicle plate have pain over the plate about half the time.
Yeah. And just regarding the muscles that get removed that you said during the fusion, which muscles are most affected by that?
Well, you move all of them.
Okay.
You move all the paraspinous muscles from the spinous stream, everything in the back out to the transverse processes gets stripped out to the side.
Okay.
If you're a good surgeon, you don't destroy or remove much muscle, hopefully. I mean, we try not to. I've seen people pull out a lot of muscle. That's probably seems icky. But the truth is, if you're fusing those levels of the spine, that part of the spine's not going to move anymore.
Yeah.
Is that muscle important to preserve? I think it is for contour and for just for post-op pain and scarring. But it's pretty. If you've ever seen a spine fusion, I mean, you have to move. You have to expose that much of the spine in the midline by pushing all the muscle out of the way and then sewing it back together. That's got to cause some causes scarring, and it causes some damage to that muscle.
Okay.
So it's not we make it as elegant as we can make it, but it's not a super elegant operation, I would say, to do a posterior spine fusion.
Okay.
Yeah.
Thank you.
Well, thank you for coming. This
Sure.
was
Thank you.
wonderful. Very interesting.
Oh, thanks. No problem. Anybody else have any questions? No?
Who's on the horse?
Oh, that's me. Sorry. We'll close that here. I'm unplugging. That's my girl.
Do either surgery impact horseback riding?
I let him go back to riding at 3 months. I mean,
Either one?
for tethers, I just kind of let him go back when they feel up to it. Because, I mean, in theory, if you fall off a horse at speed, you could hurt whatever instrumentation you have in. I don't think that's ever been reported that I know of. I do worry a little bit about kids with long, like a T4 to L4 going back to riding, because there's not that much of the spine that moves.
Right.
Just, so any sport where they're likely to fall from a height at speed makes me a little nervous. Having said that, there's really, you can't find any reports of paralysis after spine fusion associated with horseback riding or football or anything else, but it makes you a little, I just tell the family, I say, look, your motion's not normal, especially with those long double major curve fusions. So, I mean, for my purposes, it would be great to not fuse those lumbar curves, particularly the lumbar curves. But we'll see. It's a work in progress.